Hello guys, Assalamu alaikum to all my OBGY doctors and students. I hope you people are enjoying good health, and those who are unfortunately having some ups and downs in their health, we all would pray to have a speedy recovery, inshallah. And guys, I am really thankful for the response you gave on my previous lectures. Thank you so much for all the love and best wishes. And now today I am back with continuation of our last lecture, that is thrombocytopenia in pregnancy, and today I will discuss another important cause of this, that is immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura. So let's start this topic and have a quick obs and gynae review on this. So guys, as we are talking about platelets since our last lecture, so I decided to give some picture about the platelets, little bit small information that platelets are produced in the bone marrow, and the normal platelet count in a person is 150,000 to 450,000 per microliter of blood. So what are the platelets' function? They keep checks on bleeding during the blood vessel damage, and they are also responsible for the clotting, and they also contribute to the wound healing. And what about the thrombocytopenia in pregnancy? Thrombocytopenia occur in 8 to 10% of all pregnancies. So now we are going to define the condition of ITP. It is a condition in which platelets are destroyed by the immune system. Mean the immune system of the body produces antibodies against own platelets and leading to destruction of the platelets and the low platelet count. So this low platelet count causes easy bruising and bleeding, which may be seen as purple areas in the skin, mucous membranes and outer linings of organs. And this condition is thus known as idiopathic thrombocytopenic purpura, immune thrombocytopenia and ITP. So immune thrombocytopenia affects 1 in 1,000 to 10,000 pregnancies. This can be your answer, SBA. It occurs as a first presentation in 1/3 of cases. Mean patient would present as a case of first time in 1/3 of cases, and as a relapse in women with pre-existing disease in 2/3 of the cases. So first time presentation would be present in 1/3 of the cases, and in patient who is known to have ITP, the relapse would occur in 2/3 of cases. Now, as you can see in the picture, it is beautifully describing that the B cells are producing the antibodies, and these antibodies are directed against the patient's own platelets, and these are going to destroy the platelets and thus leading to thrombocytopenia. And it presents in the form of purpura, which is visible on the skin, nosebleed, gum bleeding and easy bruising. Now, what are the causes of ITP? There are multiple causes, and the most important is the body's autoimmune response against the own platelets. It can occur after some sort of viral infection, especially in children. It can occur after a bacterial infection, and some sort of genetic factors are also responsible for this condition. So pathophysiology, as we discussed, that an autoantibody directed against the platelet surface develops, which result into sudden onset of thrombocytopenia. So after binding of the antibody to the platelet surface, circulating antibody coated platelets are recognized by the Fc receptor on the splenic macrophages. They ingest those platelets and then they destroy those platelets. So now, what are the symptoms of ITP? Usually the immune thrombocytopenia may have no sign and symptom. Patient may be well in condition of mild thrombocytopenia, but when the immune thrombocytopenia purpura is moderate to severe, the sign and symptoms do occur. and they include, as we just discussed, superficial bleeding into the skin that appear as a pinpoint size, reddish purple spots known as petechiae that look like a rash, usually on the lower legs. And the patient can complain of bleeding gums or bleeding from the nose, easy or excessive bruising on the body. Patient can complain of blood in the urine or stools, and the female can complain unusually heavy menstrual flow. So you have to note one thing on examination of the patient, that there would be no visceromegaly, no splenomegaly, because this is going to help us to differentiate this condition from leukemia. So note the point that in ITP there is no visceromegaly, no splenomegaly. Now, what is the diagnostic criteria for ITP? So it is mainly diagnosis of exclusion. That is, we have to exclude other conditions that can lead to thrombocytopenia, and if those conditions are excluded, they are not present, then the condition can be called as ITP, because the name is idiopathic thrombocytopenic purpura. So first of all, we have to take a good history from the patient, in which we are going to ask about the bleeding symptoms, systemic symptoms, and any risk factor for the HIV infection, because as I have just mentioned that ITP can occur without in some sort of viral infection, thrombocytopenic purpura can occur. So we have to note down the risk factors for HIV infection. We have to check the pregnancy status, because in adults, especially in women, pregnancy is also a trigger for ITP. And we have to take medical history, that whether the patient is taking some sort of medication like heparin, alcohol, quinine, sulfonamides, and aspirin. And also, if we are suspecting some genetic disorder, we can take family history. So what about the physical examination? On physical examination, we have to look for the bleeding signs, liver, spleen, lymph nodes, and any sort of jaundice. Then we have to look for the evidence of infection, any autoimmune disease, or any sort of thrombosis condition. So isolated thrombocytopenia, this is like a buzz. This is like important clue for you in solving your question regarding ITP. That if you found isolated thrombocytopenia, what does that mean? If you found low platelet count with an otherwise normal complete blood count and blood smear. There is no abnormality found in the peripheral smear and in the CBC, complete blood picture, except for only thrombocytopenia, then it can be ITP. Okay, so if we found the absence of any other autoimmune disease, we found absence of DIC, drug-induced thrombocytopenia, there is no HIV infection, no lymphoproliferative disorder, myelodysplasia, then we can diagnose, we can label this condition as ITP. Now, the summary of the diagnosis I am giving you in the form of one-line punch for the exam. That diagnosis can be done in the basis of isolated thrombocytopenia in CBC. What is the peripheral smear showing? Normal morphology. And if you do bone marrow, it will show increased megakaryocyte if it is done, because peripherally on the blood film there is decreased platelet count, so bone marrow is getting the signal to produce more and more platelets. Now, the most important thing is management of ITP in pregnancy. So first of all, it should be managed in collaboration with obstetrician, hematologist, and anesthetist. And the aim of management is to maintain an adequate platelet count that will minimize the risk of bleeding during pregnancy, delivery, and postpartum. So, what we are going to do during pregnancy, that the platelet count should be closely monitored throughout the pregnancy, ideally every 2 to 4 weeks. And the majority of women will not require treatment in the antenatal period. Treatment is more often required to increase the count just before delivery if the level of platelet counts are less. Now, the important question which is usually asked in the exam in the form of EMQ or single best answer, that is, what is the first line treatment of ITP in pregnancy? And the answer is corticosteroids. This is the first line treatment, and with the help of this we achieve good response in 70 to 80% of women. So if we are giving some drug, we usually thought about the side effect of that drug. So the corticosteroid side effects include increased risk of gestational diabetes, pregnancy-induced hypertension, and sometimes postpartum psychiatric disorders can occur. And we all know that steroids are not teratogenic. So appropriate dose, starting dose of prednisolone could be 20 milligram per day. So you have to remember that the first line treatment for ITP is steroid, that is prednisolone. And the second line treatment for ITP is, that is, when you are asked that for refractory cases of which are not responding to the steroids or where we required a rapid increase in the platelet count, what should we give? We should give IV immunoglobulins, that is in the dose of 1 gram per kg. So this is very important exam question. You can be given scenario that the patient is taking steroid but the level of platelets is still not rising, the level of platelet is not responding to any dose of steroid, then in that cases you have to give answer in the form of IV immunoglobulin. So now, what could be the side effect of IV immunoglobulin? That women often report headaches, and more serious complication sometimes can occur in the form of aseptic meningitis and renal impairment. Now, what is the third line management for ITP? Platelet transfusion are reserved for emergency bleeding or for delivery of women with platelet count of less than 50. So you have to remember the third line as well, that in which condition you can give platelet transfusion. Now, this screenshot I have taken from the TOG article Thrombocytopenia in Pregnancy, and it is showing a journal guideline for interventional levels in non-hemorrhagic cases of ITP in pregnancy. That what should be the platelet count if patient is antenatal and no invasive procedure is planned. So normally if patient is diagnosed, is labeled as ITP, the normal platelet count should always be more than 20. And if we are planning vaginal delivery for the patient, then the normal platelet count should be more than 40 for this patient if we are planning vaginal delivery. And if we are planning any sort of, or if we need any sort of operative or instrumental delivery, then for that the level should be more than 50. And if we are considering any surgical procedure for the patient and we are planning for giving epidural anesthesia, then the platelet count should be more than 80. Okay, so all this you have to remember for your exam. This is very important slide in terms of your exam question. So what about the fetus? Because the pregnancy is not alone for the mother. Mother is holding a fetus. So routine chordocentesis is not recommended. Please remember. And we have to avoid fetal scalp sampling. We have to avoid ventouse and rotational forceps. And we have to check the full blood count from the cord sample when the baby is delivered. Now, intracranial Doppler in the neonate is usually considered if the platelet count is less than 30 into 10 raised to power 9 per microliter. Now, what about the risk of the fetus? Do you know what is the percentage of the baby having risk of thrombocytopenia? The baby percentage, the neonatal thrombocytopenia due to ITP is nearly 10 to 15%. Okay, so you can remember this as a question of yours. Now it's a time for gift slides from me. I'm happy to give you gifts. So I think everyone gets happy when he or she gets gifts. So the gifts are in the form of a very good mnemonic for ITP. And the mnemonic is very easy peasy as well. So the mnemonic is ITP mild, in which I stands for isolated thrombocytopenia, T stands for transplacental IgG, and the P stands for prednisolone as a first line, M mild bleeding usually, intracranial bleed are rare, and the lab shows normal smear, large platelets, that is megakaryocyte if we are going toward the bone marrow. And the delivery planning is important. Most importantly, the safest method is the vaginal delivery, and the cesarean sections is done only for obstetric indications. Okay, so another gift slide is in the form of a clinical scenario, because now we all have to test our knowledge, that how we have grasped the knowledge regarding ITP, and this is the time to apply that knowledge on this clinical scenario. So the clinical scenario is a 28-year-old gravida 2 para 1 woman at 20 weeks of gestation comes for routine antenatal checkup. She feels well, but on examination has petechiae on her arms and mild gum bleeding. Her blood pressure is normal and there is no edema. The lab results are showing platelets 42. So you can see here that the 42 is not good. Hemoglobin and WBC is normal, mean the rest lab results are normal, and the peripheral smear is showing large platelets and no schistocytes, and the LFTs are normal, and the patient is also giving no history of hypertension, no recent medication, no autoimmune disease. So now you can well imagine what are the questions that could be asked from you in your exam. So the first question is, what is the most likely diagnosis? So you can clap for yourself because the answer is correct, and the answer is ITP in pregnancy. So now the second question, what investigation would you do? So they have already given you some investigation, and if still you want to go with some other investigation to exclude the other condition, you can do investigation for the HELLP syndrome. For TTP, you can go with the viral screen and anti-nuclear antibody if needed. So the third question is, how would you manage? So it is also easy, that we have to start low-dose steroids because the patient is complaining of presenting with some sort of mild gum bleed. So we cannot left this patient as such. We have to start low-dose steroid, ideally the prednisolone, and then intravenous immunoglobulin if rapid platelet rise is needed in any condition. So what about the delivery planning? Vaginal delivery is good for this patient if the platelet count is more than 40, and C-section is done only if there is any obstetric indication. So now the third and the last question is, what could be the neonatal risk, which I just mentioned that the neonatal risk is 10 to 15%, and this is usually mild as well if happen. So I hope that with the help of this clinical scenario, you can have a much good knowledge, grip on this topic of ITP from now onwards. So if you want to give me suggestion regarding some other topic which I can explain to you in a better way, in the comment you can give me suggestion, and your suggestions are very much important for me as well. So this is all from me. Thanks for watching, and follow my channel for more upcoming OBGY quick review topics. So Allah Hafiz.